we have published a poster to study a specific situation where patients are affected by a carcinomatosis and they require surgery, but they have ventral hernia, surgical hernia, or they have involvement of the abdominal wall, so they require surgery for this hernia. But we don't want to make complex surgery after cytoreductive surgery. We try to find a solution to decrease the duration of the surgery. So we start to use mesh with biological mesh. So the Dr. Jelly's report a poster with around 15 cases that have been treated many years, and we have follow up the patient after the surgery to look what happens. So we see that in the vast majority of cases, we can perform with a bridge the mesh, the biological mesh, to close the abdomen, and we have no specific complication in that situation. We only see that we have to drain, because if we don't put a drainage between the skin and the mesh, there is serosa and we have complications. So now we know that we have to put a tube to through the way the liquid that happens in the postoperative course. And after we have looked on the CT to see what happens for this biological mesh. And what we have seen that this progressively disappear. So after 1 year, the mesh is very small. And after 2 years, we never see the mesh. So it's gone. But there is no big hole. There is not an hernia symptomatic for the patient. Patients are okay. Even there is something on the abdomen that you can see, but they don't have pain. They can move. There are no specific symptoms regarding that. So seems to be a good solution, because we have made first study with mesh in animal model, and we have seen that when this is a synthetic mesh in an animal model, that can increase the peritoneal carcinomatosis on this mesh. So we are quite afraid to use that mesh. We prefer use biological mesh, because in our animal model, it doesn't increase the tumor growth. But what we have seen is that first, it costs some money, and the strength of this mesh disappears progressively with time, and after 2 years, there is nothing. And the other thing that have been noted in the poster is that if we have a complication, postoperative fistula or infection, it's very important to put the mesh away. In 2 cases, the mesh stayed inside the patient, and she was progressively destroyed by the peritonitis. So it gave an abscess that continues many, many months. So it's important when we use that mesh to throw it away if we have a postoperative complication.